Okay. Thank you so much, Manoj Khatri sir, for extending your kind invitation to me and be a part of this excellent instruction course. It's a dream to be with such stalwarts in the same course, learn from them, and be able to present my work as well. It was a wonderful presentation by Dr. Chawla, so most of the points have been brought out. In addition to that, I have another point which probably will take up in the discussion. So I'll be talking about challenges in peeling vitreoretinal membranes in combined surgery. Now, as Dr. Chawla said, that combined surgery offers many advantages, including whether it is financial viability or reduced post-operative visits, ease of during vitreoretinal surgery as well. However, it comes with its own set of challenges. And these challenges could be so many fold as discussed by sir. I'll be sticking only to a few, which is peeling during peeling of membrane. So this is post cataract removal in this particular case. This was a diabetic patient who also required an ILM peeling since he did not respond to multiple injections, and the edema just wouldn't settle down. So post-cataract surgery, it was a good idea to do ILM peeling in such a situation. So after doing a good vitrectomy and peeling the posterior hyaloid, now what you can see over here is that the visualization definitely becomes difficult in such situations, no matter how good your phacoemulsification is. So it's important to quickly finish your phacoemulsification as soon as possible and make sure that the edema is comparatively, the corneal edema does not set in before you start your vitreous surgery. Yes, this is especially important when you're working close to the macula. So now you can see that the ILM peeling over here it's not as clear as when you're going through a patient who has already had surgery done in previously and the inflammation has settled down. There's no corneal edema. So this is a definite challenge in these sort of situations. Another indication where we commonly do combined surgery is patients who have an epiretinal membrane along with cataracts. Doing surgery over here and peeling the epiretinal membrane becomes extremely difficult if there is any hello. It becomes extremely difficult when there is any difficulty in visualization. So another trick over here is to use the help of brilliant blue G while peeling the epiretinal membrane post cataract surgery. As you can see, the visualization was not very great over here. But after you stain with the brilliant blue G using a negative staining, you can see over here that. So what you can see over here is that the epiretinal membrane delineates itself quite nicely once the ILM stains with brilliant blue G around it, and then you can proceed with peeling of the epiretinal membrane, whether in toto or whether you remove it in piecemeal. That does not really affect the final outcome. But what is important is to remove the epiretinal membrane as much as possible. Following removal of this epiretinal membrane, you can definitely go ahead and remove the ILM peeling, which ensures that there is no any further traction that is remaining. And subsequent to the ILM removal, since the visualization was not that great, what can also be done is, as against just using brilliant blue G to stain directly under fluid, you can fill it up with air and then use brilliant blue G. So that ensures that the staining is better. You don't need to keep it for a long time. Just a minute or two is more than sufficient. And then this is to show that we use the stain again to make sure that we have removed all the ILM around up to the macula, up to the arcades, so that there's no further chance of traction. Macular holes are by far the most common places where we do combined surgery again. Post following phacoemulsification, we peel the ILM. Now it's important to note over here that visualization can be difficult. So in such a situation, you can always switch between different lenses, from either a contact lens to a wide angle visualization system to increase and enhance your visualization. You use brilliant blue G instead of staining, instead of peeling directly. Also, what's important is that instead of just trying to aim like a capsulorhexis or a maculorhexis every single time, you can also have multiple grasps of the ILM and make sure that undue pressure is not put on the retina, because the visualization can be compromised in such a situation. So the eventual outcome is definitely going to be the same. So unnecessary traction should not be put on the retina. This is of a video of a large macular hole where an inverted flap was being planned. Now, the point I would like to bring out over here is if you see carefully over here, you'll be able to see some hemorrhages over here. So when visualization can be a problem, we can end up grasping the retina and causing inadvertent breaks if you're not careful. So it's advisable that while peeling, if you feel that you've grasped it too hard or if you've caused a retinal hemorrhage, it's better to start off at another site instead of unnecessarily struggling and trying to peel off from there itself. You'll end up injuring the retina rather than having a good outcome. Now, this particular video I have added because it's essentially the background is that the patient had a macular hole with a very high myopic eye, had a staphyloma. You can see the contrast is very the visualization is extremely bad. Apart from that, you can see that the hemorrhages are there. Now, what the hemorrhages, I caused these hemorrhages because I literally struggled to peel the ILM, which was very patchy, despite staining twice. And it was extremely adherent. So while trying to peel them with an ILM forceps, I was more traumatic to the retina. So essentially, I had no other option. And as a final attempt, what I tried to do was use the finesse loop to try to scrape off. I mean, this is not the use that a finesse loop has, but I try to scrape off whatever ILM I can from as much around the macula as possible. Fortunately, the patient had a good visual outcome. You can see the amount of pressure that's required in such a situation. Now, in many times we come across patients with macular hole RDs. Now, some of the complications that can happen over here, even though rarely, is that you can have PFCL, which we use to flatten keep the retina flat while we peel the ILM, entering the subconjunctival space. Entering the subconjunctival space either during insertion or during removal of the PFCL. So this is just another way that the case can be approached. If you have a decent visualization, if I didn't have a good visualization, probably it's not a good idea to do it. But if you have good visualization, then what one can do is peel in. What one can do is peel without the help of PFCL in order to avoid any further complications than are already there. So after peeling the ILM, one just has to be a little more careful because it's a mobile retina and one can end up creating another break over there. So following peeling the ILM, you can see that it will be tucked over here into the macular hole since it's a pretty large hole. And following this, it's also important that in such situations, you make a separate retinotomy site, what you'll be able to see over here, and never try to drain fluid from the macular hole itself. A patient with in diabetics often have their own unique challenges, and while peeling the tractional membranes and the proliferative tractional areas, it's very important that yes, I'm almost done. So what you can see over here is after peeling the tractional membrane, the ILM peeling is initiated, and you can see that the retina is quite boggy. It's actually folded upon itself. So even after removing of the tractional membranes, the retina is definitely going to take some amount of time to flatten out. And while taking this opportunity to peel the ILM, it's very important to be careful and be extremely gentle and have less evasive maneuvers while peeling the internal limiting membrane. So another patient where after cataract surgery, now visualization was fairly good, however, in this case, and after peeling off the tractional membrane, we can use bimanual techniques of surgery over here to make difficult dissections comparatively easier and try to achieve as much of traction removal, membrane removal as possible. You can see the retina over here, the macula is so boggy, and one has to be very slow and very gentle in peeling the internal limiting membrane in such situations, because as it is, we are faced with we are doing a combined surgery. So in such a situation, you have to be very, very gentle. The last video that I'll be showing is of a patient who had a traumatic. Yes, sir. It's my last video. So this patient had a traumatic retinal detachment. The cataract wasn't much, so I went in and initiated the vitrectomy. However, the visualization wasn't that great, so I decided to do a vitrectomy as well, so a lensectomy as well. Post lensectomy, the visualization definitely improved. However, there was still certain amount of corneal edema. We do have to deal with such situations also, wherein the visualization is not going to be at par. and we have to do with what we have. So in such a situation, again, what you're seeing over here is there are staphos, and peeling has to be peeling being done, removal of all scar tissue, and releasing these staphos as much as possible. Another aspect over here is after releasing that, you see even the macula is folded upon itself. So it's important to be extremely gentle in your maneuvers and make sure that you don't cause any inadvertent retinal breaks in an already compromised retina. Following this, I always put in an IOL in any combined surgery. An IOL is put, and the surgery is completed. So I thank you very much. I've already overshot. Thank you, Dr. Manoj, for bearing with my overshooting of the time. Thank you very much for your